Hi guys, I hope you guys are doing great. It's early in the morning. I just have about 10 minutes before I go to work, but I just want to quickly talk about procedural sedation. So guys, this topic, remember, this is clinical medicine. I'm telling you what we are doing in the hospital when we have a patient. So this topic is not very relevant to students, but obviously when you start working as an intern you will have to know it, but it's more relevant for interns and community service doctors, all those who are currently practicing, especially in the districts, in the rural hospitals and all of that. So procedural sedation, I got a lot of exposure to procedural sedation when I was in the districts for 3 months, and also when I was just here when I came back to complete my family medicine. So procedural sedation was called, before it was previously known as a conscious sedation. So this is a procedure, this is a kind of sedation that you can do, or that you do as a bedside. You don't need a theater for this, so you can do it in OPD, you can do it in the emergency department, as long as you've got monitors. So once you do this, a patient, after they've woken up, they are ready to go home, so there's no need for admission. So it's a kind of sedation that you do for small procedures, a procedure that is painful, but at the same time you don't want them to feel pain, you want them to experience the whole procedure, so you do procedural sedation. So the indications for this, guys, you are gonna meet a lot of them, né? Like I said, I've done a lot of these. Not that I'm experienced enough now. I still want to learn more and all of that. Like I've always said, I am that kind of an intern that I like to swim to the deep, as long as I know that I've got backup. As long as there's an MO in another unit or somewhere, I can do things that an intern cannot do alone. As long as also I'm well read about that, and I know the indications, I know the complications and all of that, so I will go and do it. So the indications are, when you want to reduce dislocations, obviously you cannot reduce a dislocation using paracetamol, or you want them not to feel the pain as you do the procedure. You want to knock them out. So as you reduce dislocations, as you manipulate fractures, the fractures that I've manipulated, I've reduced shoulders using this. I've tried to reduce an elbow dislocation using this, but I failed because the patient didn't give me a correct history. That dislocation was already old. It was more than 24 hours, so we struggled. So I had to call an orthopod to assist me with that. But I think even him, it was difficult, so he didn't do it. So the patient was taken to the orthopedic hospital. I'm not sure what they did there. So fractures that I've successfully manipulated with this is your Catlin 3 supracondylar fracture of the elbow, and your Colles fracture. I've successfully manipulated with this procedure. One other thing is your IND. When you want to do incision and drainage on an abscess, breast abscess, if it's not that big and it's not extending to all the quadrants or 2 quadrants, if it's localized and you think that you can do it, then you can. But if it's bigger and all of that, then they might need theater. So IND of abscesses in different places. Remember, you don't touch an abscess in the face. Send it to the relevant people. An abscess in the buttocks, in the back, things like that. So even Bartholin's abscess. What other procedures would be removal of foreign body, especially in kids. You know, the first time I did this, I sedated, I think it was a 4-year-old who had a millicop in her ear. Because she was so restless and crying and all of that, I was like, I'm not going to be able to get this out. I'm just going to end up injuring the kitty. And it doesn't help to call people to hold the child. We are fighting with the child to try and remove this. No, just sedate the child and then take the thing out. Because when you are doing that, you're going to cause trauma to their ear, to the passage, auditory canal, and even to the membrane. So you don't want that. So foreign body, be it in the ear, be it in the nose. I've also removed a couple of foreign bodies from the nose. So there are some kids that are old enough that will understand. You'll talk to them, you negotiate with them, then they agree, they don't cry, and then you're able to remove. But then there are those that will cry, so don't force it. So what else? There are so many indications for minor. It's minor. Basically, it's minor procedures, guys. Minor procedures, and they are not restricted or confined to this list. I'm trying to think of other. And I've also done procedural sedation on a dog bite. You know, this kiddie, I think he was like 6 years. He came in with a very big avulsed wound on the left gluteus, such that I needed not to suture but to approximate. Just to approximate. It was so flappy, so just to put a few such stitches. So, and I saw that I was not gonna win with just lignocaine. So I sedated the kiddie, and then I still gave lignocaine because I wanted to clean this properly, clean it, disinfect it, wash it, irrigate it, and then approximate it, and then yeah. What are the so the most common ones that you're gonna find, guys, in the districts? You're gonna find this, you will find this, and manipulation of fractures. If I think of other indications for, I'll just type, I'll just comment. I'll just put it as a comment. What other? Also, you can attempt it if you want to do a proper examination. Let's say you want to examine a kiddie properly, maybe in the buttocks or maybe in the vagina, but they are restless. You can do a procedural sedation. What else? Before we run out of time. So there are other. So guys, please look it up. There are other indications, but just that I don't have them in my head right now. But these are the most common ones. So now, how do you do it? Okay, the way you do this one. Oh, another thing that's gonna happen is you're gonna be called by the dentist to come and sedate the child. You're gonna be called by a dentist who want to sedate the child because they want to do tooth extraction. I've been called twice. I was shocked when they called me, and I happened to be the only doctor in OPD that day. So they said, "Doc, we want to do a tooth extraction on a kiddie. Can you come and help us?" I had to go there and sedate the child, and then allow them to do whatever that they were doing, and then yeah. So what you want to do is, you want to have monitors. This kind of procedure, it doesn't matter whether the patient ate or not. You don't need an empty stomach. You don't want them to be fasted when you do this. It's not necessary. Remember, when someone comes with dislocation, you're not gonna say, let's wait up until you are fasted. You need to reach the dislocation. So you need monitors. The monitors that you need, it's your SETS monitors. Very, very important. Your BP monitors and your... So these are the most crucial ones. But what you need an ambu bag in case you need to ventilate the patient. And then you need an IV line. Because if you do it IM, it's gonna take time for them to sleep. So you need an IV line. Yes, you are gonna need help. You need someone else to be around you, sisters and all of that. You can't do it alone. And then obviously, so there are two drugs that we use. We use ketamine and midazolam. Like I said, when it comes to doses, don't try and memorize doses. Look them up every time you need to give, so that you don't make a mistake. Like for ketamine, ketamine can be given oral, can be given IM, can be given IV. We choose the IV. And the IV dose and the IM dose are different. They are different. So when I want to check doses, I've got that app, that EMG guidelines. I have that app, so I always look it up and look at the doses, even for the midazolam. But I think it's 2 to 2.5. It's sort of like a standard, but it's important to always look up the doses. The reason why you are giving these two, there was a time I gave a kid ketamine only, as I was advised. I realized that when this kid had to wake up, she was hallucinating, having those psychiatric symptoms. But I realized that if you give the two, you minimize those chances. The reason why you give ketamine serves as an analgesia there. Remember, it blocks the NMDA receptors. So you use it for analgesic purposes. Midazolam, you want the amnesia. So in procedural sedation, the patient minimally loses consciousness, but they are breathing. They are breathing on their own. So they don't need oxygen. They don't need support, not unless the sets are dropping. But I've never had a patient who had a drop of sets. So you want this reminds me of this amnesia part. You don't want them to be aware of what you are doing, because you can take away the pain, but they are still aware of what is happening if they are fully conscious. So what you want, so this reminds me of a gynecologist that was sued. I cannot remember the country. So basically, apparently what happened is that this woman was operated, but remember, when you're operated, they use a spinal. You are gonna see you're gonna be, your level of consciousness is 15 or 15. You can even talk, have conversations and all of that. So what happened is that as they were operating her, because they did a spinal, so apparently on the roof there was something, there was like an object that was reflecting everything. It was like it had an ability of a mirror. So as she was looking there, she could see everything that was being done. So that was traumatic for her. So you don't want them to have that experience, and you can cause PTSD after that, because you don't want to. Yes, you can take away the pain, but you don't want them to see what you are doing, because it can be a psychological trauma to them. So that's why you give them the midazolam. Yes, it minimizes the chances, the side effects of ketamine, which are your psychiatric symptoms. So that's fine. So you give that. So you first give midazolam about 10 minutes before you give this. Allow it to work, and then you give the ketamine. Then you start your procedure. After you are done, keep monitoring the patient until they wake up. They wake up on their own. They'll start waking up. You will see them. And then, so what kind of patients should you consider this? When you look at your patient, it's a patient that you're gonna struggle ventilating or begging, don't do it. rather refer. I haven't done anesthesia, but when you go to anesthesia, they will tell you about how to assess a pre-op assessment. What are the things that you look for to decide if to decide how you're gonna do your anesthetic of choice, the method and everything, the drugs that you're gonna use, and all of that, and also anticipating if you might have a problem. So a patient who's obese, don't try to do it, not unless you've got a senior, because when things go wrong, when they start dropping sets, it might be hard to bag them, it might be hard to ventilate them, and all of that. So an obese patient, a patient with a short neck, rather don't try. A patient who's pregnant, don't try as well, because remember their reserves have reduced. So if something goes wrong, you're gonna struggle to so obesity. I'm sure there are others. Just I didn't prepare this. I just thought about it as I was taking a shower to work. So there are others as well. Short neck. There are others as well. So if you anticipate that you might have a problem, rather don't do it. So guys, let me go to work. Thank you.